The first DPT student chats for the University of St. Augustine. We have Dr. John Childs, who's going to speak to us about research and residencies and fellowships. And I'm going to let him introduce himself, and then we're going to take questions at the end. Thank you, Dr. Childs.
Absolutely. So first of all, can everyone hear me okay? Just kind of give me a sort of thumbs up. All right. The reason I ask is I'm not in my office. I'm actually at a resort hotel in downtown San Antonio here for a luncheon. So I escaped over here and I'm borrowing some space in the lobby. So hopefully you don't hear too much background noise around me. First of all, Brooke, thanks for organizing and hosting. I'm sure there are others who were integrally involved in setting it up. But I always like to start off by saying there's no greater group of folks that I enjoy talking to than groups of students. I'm on record for saying that basically put a group of 30 students anywhere in a room and I'll show up anytime, pretty much anywhere on my dime to just chat, share ideas, learn from each other. And so DPT students are certainly my favorite audience. My background, most of you probably know me more through my research background as much as anything. I'm obviously a PT by profession. I went through the Army Baylor DPT program in San Antonio way back when, graduated in the mid-90s. I was in clinical practice for 3 or 4 years and then went off and completed my PhD at the University of Pittsburgh, all while I was active duty in the Air Force. So I was an Air Force officer for 20 years. When I finished my PhD, I did a research fellowship in San Antonio, and then really spent the better part of my academic sort of time in the military, if you will, while I was on faculty in the Army Baylor program. And it was during those formidable years that, I had a terrific PhD experience. Tony DeLito was my mentor, who many of you know of, Julie Fritz. Got to work with folks like Jay Ergain, Kelly Fitzgerald, Lynn Snyder-Mackler, a lot of the sort of who's who, if you will, in PT-related research. And so I say all that to say this: as you start your career early on, there's probably no better advice than I can give you than to really try and connect with individuals who are in places that you want to be in 5, 10, 15 years. And don't just hang out and hope that success rubs off, but associate yourself with the best and then work your fanny off to demonstrate your value, and you'll have opportunities beyond anything you could imagine. And that was certainly the case for me. I got a great research pedigree, if you will, and it was during that time I was in Pittsburgh. We were publishing a lot of great research, but living in an ivory tower, if you will, it's very easy in academics to get isolated from the real world. And you can do all sorts of great clinical trials and sort of beat clinicians over the head for why aren't you using this in practice? And I kind of woke up, not literally one morning, but figuratively, and really thought, I've got to get out of the ivory tower. And I always had an entrepreneurial itch, and so really set out at that point to launch what has now become Evidence in Motion, which was really an effort to translate evidence, if you will, into the realities of clinical practice. And so try to align with and collaborate with quality practices who are really desiring to implement evidence into their practice. And so over the last 10 years, we've taken a lot of that and built residency programs, fellowship programs at EIM, where we can partner with employers in delivering those programs within their organizations. So a little bit, Brooke wanted me to give you just a little bit of background kind of on the research side. And I assume most of you are probably, if you ask most students what they think of when they think of John Childs as it relates to research, most students automatically point to the clinical prediction rule paper that we published in Annals of Internal Medicine back in 2004 or 2005. But it really, I would argue, doesn't typify the sort of the bulk, if you will, of what I've been up to over the last 10 or 15 years. When I was in Pittsburgh, I actually started off down a track doing a lot of knee osteoarthritis research. I was working with Kelly Fitzgerald and Jay Ergang, but Julie Fritz was there at the time. She was in the very early phases of her research career. She had just finished her PhD. She was green as could be, but as high energy and talented as anyone I had ever worked with, and worked harder than anyone else I had ever worked with. If I showed up at 4 o'clock in the morning, she was there at 3:30. If I showed up at 3:30, she was there at 3 a.m. And that I don't mean figuratively, I mean literally. She worked her fanny off and is one of the brightest individuals I've ever had the privilege of being associated with. But in any event, Julie was collaborating with Tony around the development and validation of the classification system that many of you are familiar with, the treatment-based classification system. Give me kind of a wave if you're at least familiar with what I'm talking about. At least a little bit, okay? All right, great. So the idea, right, that we subgroup patients with back pain into these different categories: patients that benefit from manual therapy, patients that benefit from an exercise intervention, patients that need a biopsychosocial approach, if you will. Because the history of research in back pain is that a lot of studies were coming up negative. Nothing was seemingly beneficial. And of course what we realized is that not all back patients are the same, and that there are these subgroups of patients who preferentially benefit from one intervention or the other. And so I got really plugged into that whole line of research and took on initially the manual therapy subgroup of that classification system, and that's where the validation study sort of came out of. Now what's interesting is that it's funny how you get quoted and judged and viewed over time based on people's perceptions about the papers you write. For example, if you ask most people what I think about manipulation, they'll give you answers like, well, I think it's an algorithm, and if you just have these 4 out of 5 criteria, you know, a monkey could manipulate a patient, because all you got to know is these 4 or 5 things, and you do this one technique, and voila, the patient's, you know, presumably better. When really nothing could be further from the truth. There's a lot more clinical reasoning that goes into decision making as it relates to manual therapy in any intervention we do. The point of these prediction rules is not to turn us into monkeys who don't think, but merely to help get us started in thinking about the optimal management strategies for our patient. And so for better or worse, these clinical prediction rules have really caught fire, and now we've seen the development of these rules for all sorts of responses to all sorts of different interventions, some of which has been positive, and some of which has frankly littered the research with a bunch of garbage out there. And certainly what we need now are a lot more validation studies to really see if some of these initial rules that were developed really hold up to scrutiny over time. So subgrouping patients with back pain has certainly been an important part of what I've done, but it's really been the last 5 years or so of my research career that I'm frankly most proud of and most excited about. Because one of the things that I've had to come to grips with is that the gap between the time data from a new trial comes out and the time that it gets incorporated into practice is a good 10 or 15 years. It's forever, in other words. So if you want to live a meaningful life as a researcher, you've got to get down into what I would call comparative effectiveness research, where you're looking at what physical therapists are doing now in practice, not what they should be doing in an ideal ivory tower world, but what is it that we're doing now that is good, bad, or indifferent, and using large megadata, claims databases, for example, to tease out the implications of the decisions that we're making currently in practice. And so I've become quite sort of convicted, if you will, that it's actually things like process of care and timing of care that matters as much or more than quality of care. Now, that surprises a lot of folks when they hear me say that, because I'm known as this sort of EBP guru. But let me give you some examples. Some of you may be familiar with some of the work we've done looking at the timing of referral to physical therapy and whether it matters if PTs adhere to practice guidelines for back pain. So we took a group of roughly 35 or so thousand patients in a claims database, and we essentially said, okay, did the patient get referred to PT early or late? And we defined early as being less than a couple of weeks, late as being anything greater than a couple of weeks. That was one piece of the analysis, and these are patients with sort of non-specific back pain. And then secondly, we said, does it matter if therapists adhere to practice guidelines? And I won't get into the details of how we determined that, but we basically categorized the CPT codes that were in the database as to whether or not they were active-oriented, sort of evidence-based codes, if you will, versus more passive codes. And what we saw was that the timing of the care actually mattered far more than even adherence to practice guidelines. So, for example, if patients were referred to PT in the first 2 weeks of their episode, the costs of managing that episode of care were cut in half. They were cut from $6,000 a case over a 2-year period to $3,000 a case. And so you can see offhand, if you extrapolate that $3,000 of savings off the over the hundreds and thousands of episodes of back pain in the United States, the savings are enormous. And oh, by the way, whether or not the care that was done in PT was adherent or non-adherent to practice guidelines was a little less relevant. It still mattered. In other words, adherent care improved the outcome further, but it didn't matter nearly as much as the timing. And so my point in saying all that is we need to be spending a lot of our time as therapists advocating not so much for our scope of practice and the ability to do this technique or that technique or dry needling or you name the favorite fad intervention of the year, but rather advocate for our overall position in healthcare and the fact that we really belong up front in the episode of care. The biggest opportunity we have to make as a profession is to get out in front of all of the high-cost, highly invasive, high-risk, and most often unnecessary interventions that are used in the management of musculoskeletal conditions. And our opportunity to influence that in educating patients that, look, back pain happens to all of us. All these things you see on MRIs and images and all these, highfalutin words we put on it, whether it be spondylolisthesis or spondylolysis, words I still can't even spell hardly. Why we label people with all these names, we actually disable our patients when we talk to them in these overtly fear-mongering, if you will, words. And we'd be much better off in communicating health and the fact that, all of our backs, have what I would call anatomical gray hair growing on them. But it doesn't mean we're sick. And it doesn't mean that when we have back pain that's necessarily explaining our pain. So I hope that's a little bit of a snippet about at least what I've been up to from a research perspective, and at least my perspective on where hopefully we see the next 10 years of research going. I'm excited about megadata. The data is in our favor. We're a high effective, low-cost provider, and we belong way upstream in the healthcare delivery system. And if we can get there, we'll have a tremendous favorable impact on the cost of healthcare, which, as we all know, are completely out of control. So, Brooke, does that give you a little bit of a just flavor on kind of a research perspective?
Yeah, I think that was excellent. I think one of the next questions that a lot of us have was, like, what's the difference between a fellowship and a residency, and why would one choose one over the other, maybe the pros and cons, or how you even go about choosing something like that?
Yeah, you bet. So,
one second. We might have a research question.
Okay.
Yeah. Do you want to save all the questions to the end, or go ahead with some research questions
No,
now?
go ahead. Let's do them while they're fresh on the mind.
Okay.
Okay, just a quick question.
Can you hear him?
Yeah, I can.
Talking about the gap that it takes to get the research from these labs into practice, and taking that and saying, okay, well, as a clinician, how are you staying on top of these things of knowing what you're doing is the best practice, or what you're doing is the most latest current literature? Do you use Twitter for that? Do you read journals? Do you spend time each day doing that?
Yeah, that's a great question, and it actually segues very well into the next discussion about residencies and fellowships. So let me give you something that's really going to depress you. Okay, half of what you're learning right now is not true. Okay, in all likelihood. The problem is we don't know which half that is. There's a lot of quote-unquote contemporary education being delivered in DPT programs all over the country that is already old. It just takes a lot of effort as faculty to keep up with the current best evidence and to incorporate that in real time into the curriculum. So don't hear me say that your faculty is in any way intentionally teaching you old material. That's just not the case. This is an inherent problem in academics across all programs in all healthcare. Medicine is probably worse in some respects because of the dogma that gets continued on year after year after year. And what happens is you graduate from your DPT program, you know, and life starts happening again for you, right? Some of you are putting off starting a family. Some of you are you're studying all the time. You're deeply diving into your curriculum. In other words, you're never going to be smarter as a PT than the day you graduate from your DPT program. And then absent some very intentional lifelong learning process, you are going to leak out knowledge every single year for the rest of your life. This idea that more years of experience is somehow meaningful, I always get a kick out of folks when you hear employers talk about, oh, well, I want to hire therapist A because they've got 10 years of experience compared to therapist B that's only got 2 to 3 years of experience. Quality of care actually declines over time on average. It doesn't go up because people's skills get stale, they get old over time. And so the only way to really arrest that trend, if you will, and not be on that slippery slope is to really invest in lifelong education. And the problem is the data would suggest that just going to a few CE courses here and there, when you graduate, depending on where you're licensed, what state, you're going to have continuing education requirements to maintain your licensure. In Texas, it's roughly 30 hours every couple of years. Well, that's a drop in the bucket. You can get 30 hours going to one CSM conference practically every 2 years. And I can sit in a big auditorium and listen to people drone on and on and on and lecture at me and satisfy my licensure requirements. All the while, my psychomotor skills are getting old. I'm not keeping up with current best evidence, new techniques, whatever it may be. And I lull myself into a false sense of security, especially in a profession like ours, where patients don't die from our services, right? So we don't have lots of patients that confront us with not getting better. And so we can easily think that our skills are up to date when in fact they're getting old. And so to answer your question, it's really a comprehensive lifelong learning strategy that will set you up for long-term success. Absent you're doing that, again, I'm going to depress you here for a moment, but absent you're doing that, your practice 15 years from now is going to look a lot like it did your first year after PT school. So when people tell me that they've got 10, 15 years of experience and they sort of are using that to kind of tout their somehow the quality, I always ask them, I say, well, is your 15th year of experience just like your first year? In other words, for many people, their first year of experience is just like their second, is just like their third, is just like their fourth. They've got 15 years of the same type of experience. And so what you want to see is a true progression, diving into things like residency training, fellowship training, um, methodical monthly journal clubs, study groups, continuously sort of progressing your career. Because small doses of education don't change behavior, but long-term program tracks where you sort of indoctrinate yourself, if you will, into a learning method, those influence and change your practice, over time. And I can speak to you in my own example, and then we can talk about it in residencies and fellowships. When I graduated from PT school, master's programs were all that was there. Creighton may have had a DPT program, but it was the only one in the country at the time. You guys take for granted now that every program in the country, right, is a DPT program. And so as a result of that, the didactic curriculum has been elevated, and you guys are graduating. You're getting better content than I did when I was at your stage. When I was at your stage and graduated, there were no residencies or fellowship programs, or very few. And so people like me, the way I sort of kept up, if you will, was chasing weekend CE. I probably spent 15 or 20,000 of my own dollars in the first couple years of my career going to every course known to mankind. And so that there was no program track or sequence of learning called residencies and fellowships. Whereas you guys now can come out of school and you've got opportunities to complete residencies and fellowship programs. Now, to your question about differences between residencies and fellowship. Residencies are really geared towards the new grad to elevate your clinical skills, and in some cases to remedy, frankly, some not so great clinical education experiences that you may have had in your entry-level program. Clinical education in DPT programs is a big problem. And we could spend an entire sort of hour just hearing about some of your clin ed experiences, and by no means a fault of your DCE. So please don't go telling your DCE I'm suggesting your clinical education is bad. But when you're in your didactic phase of your program, you've got a curriculum, right? To show up at this point for this class, you're going to learn this topic and do these readings. When you show up for clin ed, you sort of show up, and your CI sometimes is surprised that you're actually there. They forgot that you were coming, right? And you sort of catch what you can. It's sort of a learn by osmosis strategy, as opposed to a real intentional curriculum that's you can reach out and touch and feel. You hope that you learn, but it's not methodical in most cases. And in many cases, clinical educators are far removed from the academic program. They're not even all that familiar with what you've been taught in your entry-level program. So residency programs are a chance to enhance and build upon your entry-level experience while your brain is still spongy enough to learn. Frankly, as we get older, our ability to learn new things, sort of declines. So you're in that, prime sort of spot to continue your learning. You're already in an academic mindset. So residency is really for mostly entry-level PTs, and it's designed to help prepare you for board certification. So the orthopedic specialty exam, the sports exam for for sports residency, the NCS in the case of neuro residency, et cetera, et cetera. So it is sort of the what you do when you graduate from PT school. Residency programs are at a similar stage now as the DPT was 10, 15 years ago. Now everyone goes through DPT. Some go on to residency programs, whereas if I have a crystal ball out there, residency is the next big thing coming in our profession. Now that we're past the DPT, my guess is 10, 15 years from now, virtually everyone that graduates from a DPT program will go on to residency training. Fellowship programs, on the other hand, are really geared for, you can think of them as subspecialties. So let's use the medicine analogy. If I go into medicine, I go into residency and I do family practice. I do orthopedics. I do general surgery. I do a general specialty. And then some go on to subspecialty. Excuse me. Some go on to subspecialty. So if I want to go be a spine surgeon, for example, Lord help me if I ever want to go be a spine surgeon. But if I ever wanted to do that, I would go do a spine surgery fellowship program, subspecialty off of orthopedics. Same thing is true for fellowship programs in our profession. Fellowship in manual therapy, for example, is a subspecialty, if you will, off of orthopedics. Now, if you look at the way our profession's evolved, you'll see a lot of manual therapy fellowship programs that you can sort of enter into directly after PT school. We've got the cart before the horse. We sort of built fellowship programs before we built a strong base of residency programs. So it's kind of confusing, because if you look at some fellowship programs, their content and curriculum is actually more akin to a residency program than it is a fellowship program. One of the things that's just changed to try to address that is, to get into a fellowship program now, you actually have to be board certified already. In the past, board certification was not required. Board certification is now required to get into a fellowship program. So fellowship programs are also designed not just to teach you sort of fancy hands-on skills, but really to help position you as a leader in the profession as well. So it's about leadership. It's about learning those advanced sort of decision-making skills that go sort of above and beyond residency. Interestingly, applications to residency and fellowship programs are starting to shift to the centralized application system in much the same way I suspect most of you applied to PT school. So residency and fellowship programs are now housed within their own centralized application system. You don't have to use that system, but that system is becoming more and more common. I will say there's not enough residency programs around the country. There's probably 300 to 400 applicants for residency programs and perhaps only 100 or so seats that are available. If you look at how most residency programs are built, they're not that different from clinical education settings. You know, you go work with a mentor in kind of a one-on-one model, and they sort of patch together sort of a curriculum and build it, brand it as a residency. And those can be great experiences. But it doesn't really help to solve the problem of we have a lot more individuals wanting to do residencies than we have opportunities. And that's in part really our mission at Evidence in Motion has been to build an enterprise nationwide opportunity of residency programs in partnership with high quality practices. So if you look at where a lot of real great clinicians live and work, they tend to live in, there are a lot of places, but especially small practices, small private practices, and they would be out of their mind to try to go build their own residency program. The infrastructure that's required, all the credentialing, it's just not worth it for only 1 or 2 residents every couple of years. And so at EIM, we have built a residency program that we can then align with any board certified clinician that's interested in bringing a resident into their practice. So you can essentially have residency wherever you live and wherever you work, as long as you have access to a mentor. And so the didactic curriculum is delivered in a blended model, a combination of online, flipped classroom style curriculum. You get to interact with a lot of different faculty, as opposed to just sort of putting your entire residency experience in the hands of one individual. I always say if you wanted to do a residency with me and just me, you'd get a really subpar experience, because there is no way that as an individual I have the full universe of knowledge that you're deserving to learn from. So at EIM, we try to crowdsource the best of faculty from around the country that are really experts in their key field, and have you be able to consume all of that from all of those folks. So and still get very high quality local hands-on mentorship. And then the fellowship program is structured in a similar way. So that's just a little bit of background on sort of residencies and fellowship programs. And Brooke, maybe it'd be time now just to open it up for questions, or feel free to give me some other topics that you think folks would like to hear about.
Do we have any questions? Yeah. Go ahead, Bob.
Yeah, just be sure to speak up. I can, but not great.
Bob?
Yeah. I really have two questions. My first question is, how to get involved in the residency, and what's the cost? Do we go seek out a mentorship in our city that we're going to live in, and then from there contact you guys, and how does that process work? And second, for us, what actions do we need to take to bridge that gap between clinical evidence and becoming forefront practitioners in the medical model?
Yeah, great question. So you obviously can learn a lot about EIM residency and fellowship programs on our website. So that's one resource to go to. Applications are there, information's there, and there's really a couple of models. And I don't want to just speak just to EIM residency. I'm obviously biased around our residency program, but there's a lot of other quality residency programs around the country. Most residency programs are what I would call a full-time hosted model. So in the typical residency program, you graduate, you move across the country to wherever your residency mentor is, and you work for a residency stipend, typically 60–70% of what a base comp would be, in exchange for that employer offering you residency. And you go through a credentialed residency, and at the end of that period of time, you're eligible to sit for your board certification exam. So you can think about it as sort of DPT plus, if you will. Yes, you're making a living now. You're starting to make an income. You're a licensed therapist, but you're not making a full compensation because the employer's providing residency training. We have that option available at EIM. So we have mentors all over the country who are accepting and wanting to hire residents in that model. Now, on the other hand, one of the big problems we have in PT and going to a private institution like St. Augustine or any of the other ones, I'd be kidding myself if I want to ask you to raise your hand, but my guess is more than half of you in the room are going to have north of $100K in debt when you graduate from school. And I see some smiles. I suspect that's fair to say. And so some of you are thinking, well, how in the world am I going to work for, $30,000, $40,000 a year in my first year after PT school to do residency? So that gets to the other model that we have at EIM, which we call our independent model, or our part-time model, where you go work for an employer who will sponsor in part your residency, but you're working full-time in the practice. You're a full FTE, and you're completing most of your residency requirements in the evening on your own time. So that's another model that allows you to earn some more income, but at the same time complete the residency program. It may take you 1.5 to 2 years versus a year, but it's an option for those individuals who can't complete a hosted model. And so you can contact us. There's links on the EIM website to reach out to us if you're interested. You can also find us. We are in the centralized application system for residency and fellowship programs. I guess I would put it this way. There's an application fee in that system, and it's not required. So if you're interested in EIM programs, feel free to reach out to us directly. You can contact us at info@eimpt.com. And again, that info is on the website as well. And so to answer your second question about how you bridge that gap, in part, you bridge that gap by staying in some form of lifelong learning for the rest of your career. Now, I'm not suggesting you're going to be in a residency program or fellowship program for all of your career, but some form of ongoing learning. And maybe I'm a glutton for punishment, but I can't count. I can count on one hand the number of years since I've graduated from college that I have not been in school. I mean, I finished PT school. I went out. I did an MBA. I did a master's program in PT in Pittsburgh. I did my PhD there. I went back, did my transitional DPT. I'm probably about to start an executive coaching program at UT Dallas. And it's that ongoing, lifelong engagement in learning. Some of it, yes, formal, but a lot of it informal. I'm still an active part of a journal club that I was a part of when I was a brand new therapist, and that meets on a monthly basis just to chat about a sort of a contemporary sort of article of the month, if you will. And so it's those kinds of intentional kind of efforts, habits. That's maybe a better way of saying it. You want to start knowledge habits early in your career that are sustainable. It's not sustainable to be in a DPT program for the rest of your career, but it is sustainable to commit 30 minutes, an hour a week to learning for the rest of your career. I'm involved now in starting an entry-level DPT program. That's kind of our next big thing at EIM, and this gets sort of beyond the purpose of our discussion. But we think PT school is too long. We think 3 years is too long. We think you can do it in 2 years and save a year of tuition and get students into residency programs in year 3 of what otherwise would be year 3 of an entry-level program. So we think that it's really possible to do DPT plus residency in 3 years rather than just DPT in 3 years. And I say that to say this: I am seriously debating. I'm going to have to convince my wife, but I am seriously debating about actually going through our DPT program as a student and starting over, because I am dumber now than I was probably 2 or 3 years ago. I laugh when students talk about taking the licensure exam. I'm scared to think about how I would do on the licensure exam if I had to retake it right now. And so, my point is, it's that constant, ongoing frustration frustration that I don't know everything I could know, that drives me to continue learning. And you don't have to be on the sort of the extreme scale, if you will, that I'm on. I mean, I'm admittedly a complete dork and a geek, but something in the middle is a good place to be for the rest of your career.
All right, John, I think we have a few more questions.
Hey, John, I was just wondering, like you said, we're all going to graduate from debt. I think that's true regardless where you go to school. But how do you sort of weigh that paying off that debt when you grad? Do you recommend residency out of school, make some money in the meantime?
Brooke, I'm having a hard time hearing that question. Could you rephrase that one real quick?
He's coming up.
Oh, okay, perfect.
I was just wondering, you mentioned now everybody graduates PT school with a lot of debt. I was just curious how you could weigh the cost of paying those debts, graduating and pursuing a residency program versus finding mentorship sort of in that private practice or hospital setting, whatever you choose, or kind of starting a residency maybe a year or two out so you have some time to sort of build up that financial for yourself.
Yeah, great question. And I think about this now. When students ask these questions, I now think about this in the context of my own kids, because I've got 2 teenagers that are, beginning to contemplate what they want to do when they grow up. And I don't say this to be discouraging to any of you in the room, but I have a very hard time as a father recommending my kids go to PT school and get 100K in debt, because the return on investment, you're going to be in debt. It's a great career, don't get me wrong, and you'll do fine. You'll be able to, you're not going to, go bankrupt. You'll be able to pay your debts and that, but you'll be strapped for a number of years. It won't be easy on you. So I guess the first thing I would say is try to minimize as much of your student debt as you possibly can, realizing that you're sort of past that point now. So by all means, soak it up, learn the best you can. Now, to answer your question, if you've got over 100K in debt, it would be hard for me to recommend that you go do a full-blown, what I would call hosted residency, where you go work for $30,000 a year, because you need to get out there and start, paying off your loans. Now, if you are of that mindset and you really want to do it, great, go do it, but try to defer your student loans. Most residents, most at least federal loan programs, you can defer your student loans while you're in residency. It depends on the type of loan that you have. There's a lot of nuances, but most of the federal programs will allow you to defer your loans. A good option is that model I alluded to before, what we call at EIM the independent model, or part-time residency program, where you can go work for an entry-level compensation in a high-quality practice, access to mentorship, completing residency requirements part-time. For example, in our practice in Texas, we recruit all new grads around residency, either in the hosted model, depending on their life circumstances and desires, or the independent or more part-time model. And we have therapists that are in both models. And for those therapists that are in the part-time model, we pay for 50% of the expenses of residency. We actually pay for 100% of it, and then the employee pays us back 50% over the time that they're in the residency, because most students, when they come out of school, can't write a check. The costs, I think somebody asked about that before. The cost, it depends on the residency program. At EIM, our residency program is between $10,000 and $12,000. If you're in the hosted residency model, where you work for a residency stipend, in those cases, the employer usually covers 100% of the residency tuition. You're sort of paying for some of your residency, if you will, in the form of a salary offset. In the case of the part-time model, it ranges. Some employers pay 100% of the residency costs. Some, like us, we pay 50%, and others don't cover any. It really depends on the individual provider. At TexPTS, and by the way, I should have said this early on, I kind of wear different hats. I function as the day-to-day CEO of EIM, but I'm also a partner in TexPTS as a practice, and so we invest a lot of resources with EIM because we recruit around residency and fellowship. We used to pay for 100%. We only pay 50% now, because our experience has been when students have skin in the game, they just invest more. They're more committed to the program. So there's different ways of funding it, but if you've got a lot of debt, it's hard to argue against going out there and getting a job first. Does that help?
I think we have another question.
Sure. I guess on the other end of the spectrum, for someone that's really ambitious and does a lot of the self-monthly reflection on their own and will do a lot of continuing education and training, is a residency even necessary? If they have to complement their first coming out of school?
Yeah. So if I understand your question right, if you've got access to a good mentor, there's decent CE out there that you can sort of package together on your own. Do you really need to do residency? And I think it's a fair question. I think it really depends on sort of where you are, stage of life, your interests. If you sort of piecemeal it, the onus is on you to try to figure out what's most important and what you should learn, and those kinds of things. The one thing a residency, especially in the hosted model, will give you is when you graduate from a credentialed residency program, you can immediately sit for board certification. If you don't go through a residency program, you have to petition to sit for board certification through the portfolio development process. and that requires a certain number of hours in practice, and depending on whether you're full-time, part-time, even if you're full-time, it's roughly 3 years from the time you graduate that you can potentially sit for your board certification exam. So completing a credentialed residency can usually get you a year to 2 years ahead of the game in terms of being able to sit for board certification, to the extent that's something that interests you. Now, the proverbial question is always, well, what does that get you? Well, obviously, it gets you an elevated knowledge set. I'm of the mindset that the industry is going to contract over the next 5, 6, 7 years, and we're already seeing this in hospital systems, for example, where 5 years ago jobs were everywhere, and now jobs are starting to they're not as common as they once were. So things like residency training, fellowship training, board certification, those sort of differentiators will matter more and more in a tight job market. And so if the market gets tighter, and as the market gets tighter, those sorts of things become more valuable assets to have, above and beyond just the pure sort of ecumenical value, if you will, of doing those things because it's the sort of the right thing, if you will, to do. I by no means think that residency is necessarily for everyone. I see therapists that are 2 and 3 years out of school that have really been lifelong learners. I mean, they've piecemealed it together themselves, and recommend some of those folks go straight into fellowship as long as they have their board certification. So it's one of those things I encourage people to seriously consider it. In some cases, here's another example. In some cases, depending on where you are, you don't have access to a board-certified mentor. You don't have access to an OCS therapist that can give you those 140 one-on-one hours that are required for residency. In those cases, that's why we have certificate track programs at EIM that essentially allow you to go through the full curriculum. It's essentially residency without all of the mentorship requirements. Now, the mentorship requirements in many cases are helpful, but in some cases they're sort of burdensome because they're sort of fraught with a lot of regulatory things that get put on credentialed residency programs. So certificate track programs are another less expensive option to get a lot of the knowledge and expose yourself to and connect with the faculty, but not have to complete all the mentorship requirements.
Does anyone else have any questions? Well, John, thank you so much. It's about time to get back to class. Lunch is almost over, but we really appreciate it.
All right. Absolutely. Well, hey, it's been my privilege. Thanks for your time. And let me just finish real quick. You can find me on Google, cell phones out there, emails out there. Reach out anytime. Brooks got it all. I'm happy to connect with students. Glad to chat with you, whether it be about EIM programs or other things you're considering. I really mean it when I say it's a privilege to connect with students. So stay in touch, and please don't hesitate to let me know if there's anything I can do. And I wish you the very best in your program. Take care.
Thanks.
Thanks, Brooke.